Good afternoon and welcome to this bill hearing for the House Health Committee. I'm Chair Heather Bagnall. I ask for your patience if we encounter any technical or streaming issues. This hearing is being streamed on the Maryland General Assembly YouTube channel. Now, please note that food and beverages are not permitted in the gallery. Delegates may have drinks at their desks as these meetings can run long and hydration is essential. Please make sure to turn off your phones or put them on silent. And if you see members who are not present, please understand that they may be attending other official meetings, they may have hearings in other committees, but they're remaining informed of our proceedings. Please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist, and please keep your questions brief and shorter than the answers. Today, we will be taking our bills in this order: House Bill 278, House Bill 367, House Bill 162, House Bill 215, House Bill 393, followed by House Bill 88. House Bill 278, that's the Department of Aging and Commission on Aging, the Longevity Ready Maryland Act. Human Services, if you want to come to the table, and you can get started when you're ready. Oh, as a reminder to all of our witnesses today, the sponsor will have no time limit. Please keep that within reason so we don't have to revisit it. And all other witnesses will have 2 minutes. Welcome back, Madam Secretary, and you can go ahead and get started.
Good afternoon again, Chair Bagnall and Vice Chair Cullison and members of the Health Committee. It's really my pleasure today to be here in support of our departmental bill, HB 278, the Longevity Ready Maryland Act. You have our written testimony, and as you know, we just talked to you about our plan, so I feel very fortunate to be able to do this quickly, right behind having explained the plan itself. This landmark legislation permanently enshrines the importance of planning for our growing older population. Aging is a biological and deeply personal reality. Aging is also a population phenomenon. The population collectively ages as individuals live longer lives. In our world, in our nation, and in Maryland, we are in the midst of a massive population disruption caused by living longer lives and falling birth rates. We have a society that is built upon retirement at age 65, but many of us can live up to 3 decades past that age, and fully half of today's 5-year-olds can expect to live to be 100. When I talk to my financial planner, he says actuarially I should live to be somewhere in my 90s, and planning for that is different than planning for a life that maybe you live a couple of years past 65 and collecting Social Security for the first time. The norms, the systems, the policies, the laws, the programs of the last century are not sufficient to meet today's longer-lived society. 2 years ago, the governor issued an executive order for Maryland to begin this planning work. In July of this year, the governor signed the Longevity Ready Maryland Multi-Sector Plan on Aging. There are over 70 specific recommendations, as you know, in our Longevity Ready Maryland plan, which is incorporated by reference into this bill under our 4 overarching goals for all of our work: building a longevity ecosystem, promoting economic opportunity, preparing state residents to afford longevity, and optimizing health, wellness, and mobility. Very importantly, this is not about a Department of Aging plan. We do, in fact, have a 4-year state plan, which we are required to put forward every 4 years. This is a multi-sector plan approach that includes not only all of government, but sectors outside of government. And it commits the state to using the lens of longevity when considering planning, policy, and legislation. This bill does not commit the state to current or future new cost. We are at an inflection point. In 4 years, a quarter of Maryland's population will be over the age of 60. And this bill is a very important next step to modernize and update the role of the Department of Aging to lead, guide, and support the multi-sector state approach to preparing for longer lives now and into our future. The 10-year multi-sector plan and the bill are very heavily influenced by our stakeholder engagement over the past 2 years. We have been very intentional and consistent in engaging with our 19 local areas on aging, our sister agencies, and key external stakeholders. The department has agreed to the amendments you have in your written testimony that are a direct result of that engagement. Our bill proposes a modest expansion and realignment of the Commission on Aging's membership. We also propose comprehensive updates to the full Longevity Ready Maryland plan every 4 years, while giving our successors reasonable flexibility to make changes to objectives and strategies in the future. To briefly address our sponsor amendments, they are as follows: to commit the department to its current practice, maintaining a publicly accessible Longevity Ready Maryland plan implementation progress tracker on our website. Increase representation from area agencies on aging on the Commission on Aging from no seats, as they have now, to 3 seats in the future. Add a dedicated seat for a veteran with interest in Longevity Ready Maryland to the Commission on Aging at the recommendation of our friends at the Department of Veterans and Military Families. Add some clarifying language from the recent federal final rule under the Older Americans Act that informs our state plan on aging. Our goal here and in the entire bill is to be as clear as possible about our role as an agency going forward. The Longevity Ready Maryland Act puts Maryland at the forefront and makes a commitment to the multi-sector on aging framework to address the challenges and maximize the benefits of longer lives. With that, I request a favorable with amendments report for HB 270H, the Longevity Ready Maryland Act, and we would be glad to answer any questions you may have.
Is the rest of your panel here for questions?
Testimony from our partners at the Department of Veterans and Family Affairs.
That's what I thought. So you can proceed with your testimony.
Okay. All right, good afternoon, Chair Bagnall, Vice Chair Cullison, and members of the Health Committee. For the record, my name is Jimmy Anderson. I serve as the Deputy Secretary of VA Operations at the Maryland Department of Veterans and Military Families. I'm also a proud resident of House District 20. I show up today as a post-9/11 veteran with 16 years of service in the Air Force, an oath of service that continues today in the Air Force Reserve. I'm here to offer our department strong support for House Bill 278, the Longevity Ready Maryland Act. For the department, this isn't just an aging policy. This bill represents a fundamental shift in how Maryland prepares for its future. It is a promise. It is a promise to our veterans that their final chapters will be written with the same dignity and purpose they earned in the first chapters of service. Maryland is home to over 360,000 veterans, and our population is aging. At Charlotte Hall Veterans Home, we see this reality every day in the faces of those requiring skilled nursing and assisted living care. And the data is clear. 41% of our veterans, nearly 150,000 Marylanders, are already 65 years or older. By 2030, this segment will surge as our Vietnam veterans continue to age. By integrating the needs of our veterans into the Longevity Ready Maryland plan, we ensure no one is left behind in our state. We also strongly support updating the commission, thank you, Secretary, on aging to include a designated veteran. We need that lived experience at the highest levels of policy and implementation. The Longevity Ready Maryland Act ensures that those who served our country can age with purpose, security, and dignity right here in the state that they call home. On behalf of the department and those who serve, I respectfully ask for a favorable report with amendments on House Bill 278. Thank you.
You can start your testimony.
I don't have any additional testimony. I'm here for questions.
All
General
right,
Crawley.
thank you very much. I'm going to open it up to questions from our members, starting with Delegate Kaufman, followed by Delegate Hill.
Thank you. Madam Secretary, one of my big fears is that as people age longer, live longer rather, and we try to get them to age with dignity, there are not going to be enough personal care attendants to assist them with personal tasks like showering and shaving and dressing. And so is part of the plan, which sounds very exciting, to partner with Secretary Wu to ensure that there are a sufficient number of personal care attendants to help with intimate tasks as people age? Because that is often the difference between being included in the community and not.
Thank you for your question. And I think it goes right to the heart of the matter in many ways. It's why, in fact, this is a multi-sector plan, an all-of-government approach, because the Department on Aging receives about 5% of the funding that comes into the state to address these kinds of issues. And so we have to partner with our sister agencies in order to address these complex issues. So the answer is very much the plan recognizes the need to grow the care workforce. And I have been relatively outspoken in my work with the Governor's Workforce Development Board, the subcommittee that I've worked with on accessibility, and been very clear that if we want there to be more of a care economy and more care available in our state, that those jobs of caring for our most vulnerable residents must be good jobs. And so we're working on what does a good job look like? And it has lots of different parts to it. It means that people are well prepared for the work they have to do. It means that they have a family living wage that they are able to obtain from their work. It means there are opportunities for upskilling, reskilling, advancing, and career pathways. And it means that their work is honored and appreciated. And so I think that there is a lot that's already being looked at in the state about how do we grow the healthcare workforce at all levels of the profession. You know, we have a family care, a family physician deficit in our state, and we have lots of different kinds of healthcare professionals where we have not enough to meet the needs. And that is very much true of frontline staff. And so we're going to continue to work with the health department and other agencies that are concerned with building the care workforce for the future. And also for right now. The shortage is impacting the state right now as well. So thank you for that question.
Thank you, Madam Chair.
Delegate Hill.
Thank you, Madam Chair, and thank you so much, Madam Secretary, for the work and for the presentation and then for the bill. I love the idea of all of government, whole of government approach. My question really has to do with the fact that in this bill seems to do a lot of describing sort of in broad terms what the plan is, but in so doing, you've also deleted very specific functions of the department. and I'm not sure if the plan is supposed to supplement them or supplant them. So for instance, on page 3, what is deleted is programs and services in the areas of income maintenance, public health, mental health, housing and urban development, employment, education, recreation, and rehabilitation. They're not then put anywhere else in the bill. So without clarity about what it is that we're going to, are the nanny grants going to continue, the aging, I'm not clear what continues and what gets completely wiped away, and the longevity planning then decides what to put back when all this is removed from statute. So can you help me understand that?
I think that, first, thank you for that question. One of the things that we were trying to do in codifying the plan into law was to use the broad categories to sort of capture more of the sort of specifics that were outlined. And I think part of that is because it's a 10-year plan. We don't know specifically yet. I mean, that's part of what we need to work on. What areas will end up having the most impactful priorities available as the plan moves forward. And we also know that this is a plan that does include all the aspects of living in our state as an older person. And the things that are sort of not specified don't mean that they won't be addressed. It is comprehensive in that it isn't a plan that looks at just your health, just your financial security, just your ability to be part of community, not be socially isolated, just the part of your life that says that you are an important member of society and that you can live a life of purpose to the very end of your life. And so those things are captured in the 4 essential goals, and I think will be absolutely played out in very specific ways over the next 10 years. I hope that that answered your question.
It answers the question. Thank you.
All right, I see no other questions from the members, so I just wanted to ask, while you were here at the table and could answer, there were a couple of proposed amendments that are, I don't think are incorporated. One maybe, one was from the Maryland Senior Citizens Action Network to incorporate strategies and elements from local area agency on aging plans and other relevant local plans. Is that incorporated into that 3 directors of an area agency on aging, which shall include the president of the Maryland Association of Area Agencies on Aging?
I could let Deputy
Sure.
Secretary answer that.
Hi, thank you for the question, Madam Chair. That specific amendment, we are still discussing, and we are happy to partner with MSCAN and our partners at the Area Agencies on Aging to discuss further.
Thank you very much. And then there was a second one from the Economic Action Maryland Fund that just, it spoke to the concern about consumer protections and complaints of elder, of elder abuse and fraud, that said adding 1 additional expert on aging representing the disciplines of healthcare, technology, academia, innovation, and then adding consumer protection into that list of, and the private sector and philanthropy. Is this something that's under consideration?
It is under consideration. Yes, we've been having those conversations as well.
Thank you very much. And I see I have a question from Delegate Lopez.
Thank you, Madam Chair. So I'm looking at the text of the bill, and there's lots of changes to the commission. Oh, excuse me. Lean up a little bit here. So looking at the text of the bill, there's lots of changes to the Commission on Aging. And I'm wondering if you could just kind of summarize all of these changes and what they represent and what the philosophy was behind changing them.
Our goal in thank you for the question, and also congratulations on your new position with the subcommittee. The goal with the changes to the Commission on Aging was to have the commission be able to be better positioned to advise the department on priorities that are multi-sector in their scope. And also to ensure that we had good representation from the local local areas on aging. There are 19 of them, because they're the ones that actually deliver programs and services at the local level. And so wanting to be sure that they were included when priorities were being established and discussions were being made. So our thought was the committee needed to better reflect the world of academia, where so much research and innovation is going on, and frequently that we have some of the world's foremost universities in public health and in research and aging, to make sure that finds its way into informing the work of the department and the plan, as well as sectors that involve providers, creating a longevity economy, the things that we know are not specific in the way that perhaps previously we looked at a specific program for older people, but broaden the framework. So we are sort of adding on. This is not, we're going to do this instead of this. It's, we're going to broaden the membership, be more inclusive and focused in ways that fully inform the agency in the implementation of the plan. We think that is really necessary, so there continues to be really robust stakeholder involvement, close stakeholder involvement in actions that implement the plan in terms of program services, legislation, funding. And so that was the intention, was to give them that significant role as a commission, broadening that responsibility. Thank you for the question.
Seeing no further questions, that completes the testimony by this panel. Thank you very much. We're going to bring up a panel, and it's favorable and favorable with amendment, because I suspect that a lot of these amendments are captured in the sponsor. So can I bring Sarah Westrick, Stephanie Archer-Smith, Allison Saborowski, Owen McAvoy, please forgive me, Allison Saborowski, oh, you're on there twice, sorry, and Ann Seacott. And if I have spoken not spoken in earnest, please feel free to make us aware as well. You can get started with your testimony.
Good afternoon, Chair Bagnall, Vice Chair Collison, and members of the House Health Committee. Thank you for the opportunity to testify today. My name is Westrick, and I'm the Advocacy Director for AARP Maryland, and we proudly support House Bill 278, the Longevity Ready Maryland Act. AARP Maryland represents more than 850,000 members across the state, making it one of the largest member-based organizations advocating for older Marylanders. We welcomed the launch of the Longevity Ready Maryland initiative in January 2024 and served as a key stakeholder in the plan's development. The comprehensive 10-year multi-sector plan aligns state, local, nonprofit, and private partners to strengthen aging services across Maryland. The plan also aligns with AERP's mission to empower people to live their best life as they age. Maryland is entering a pivotal moment as our population is rapidly aging. We must ensure our systems, services, and communities are prepared to support older adults with dignity, independence, and opportunity. House Bill 278 strengthens the leadership and the structure needed to meet this moment. It enhances the role of the Secretary of Aging, modernizes the Commission on Aging, and promotes transparency and accountability, all while ensuring that the Longevity Ready Maryland plan stays responsive to changing needs, research, and best practices. As a state, we need this bill so we can make the implementation of the Longevity Ready Maryland plan a reality. Age-friendly planning benefits everyone. When we design communities with safe streets, accessible housing, and reliable transportation, as well as opportunities for connection and lifelong learning, people of all ages benefit. This legislation is about more than aging. It's about shaping a Maryland where every person at every stage of life can thrive. AERP Maryland respectfully urges a favorable report on House Bill 278 so we can build a stronger, more equitable, and more age-friendly future for all Marylanders. Thank you.
Thank you, Madam Chair, Madam Vice Chair, and members of the committee. I'm here today on behalf of Leading Age Maryland in strong support of House Bill 278. Leading Age Maryland is a community of 150 nonprofit aging services organizations that provides housing, services, and care to more than 20,000 older persons every year. Leading Age Maryland had an active role in the development of the Longevity Ready Maryland plan. I personally served on the Stakeholder Advisory Group, as well as the Preparing Marylanders to Afford Longevity Work Group. And being intimately involved in the development of the plan, I saw the intention, thoughtfulness, inclusivity, breadth of diversity of stakeholders that really went into the development of this plan. But now the real work begins, and I'm so excited to see the opportunity to codify this important work into state law to ensure that it's protected and can carry on in the years ahead. And this is not only professionally a passion of mine, but I want to share just a quick personal story. My mom is a retired hospice nurse. She was a hospice nurse for more than 30 years, and she wants to move to Maryland to be closer to me and to my kids. But that's turning out to be really challenging because there's not a lot of affordable and middle income options for older adults in Maryland. So I am excited to see how this plan can help ensure that we are better using our housing resources in Maryland to make housing more affordable and accessible for grandparents and other older adults in our state. Additionally, this plan aligns with Leading Age Maryland's mission to support policies that enhance aging services, strengthen our care systems, and expand opportunities for older adults to age in place with dignity and choice. So we urge a favorable report on House Bill 278. Thank you for your time.
And Ms. Siborowski, can you just state your name for the record? And
Oh,
so
yes.
I can learn how to say it.
It's Allison Siborowski.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. Thank you for the opportunity to submit this favorable with amendments testimony for House Bill 278 on behalf of Meals on Wheels of Central Maryland. My name is Stephanie Archer-Smith, and I serve as Executive Director and CEO of Meals on Wheels of Central Maryland. For more than a decade, I have led this organization that serves over 5,000 older adults annually, delivering more than 1 million meals each year and providing comprehensive support services that help Marylanders remain safe and independent in their homes. I also had the privilege of serving on the steering committee that helped develop the Longevity Ready Maryland plan. Meals on Wheels of Central Maryland favorably supports with amendments House Bill 278 and appreciates the Department of Aging's leadership in advancing a coordinated approach to longevity planning. There is no right or wrong way to age, and aging is not served by a single agency or a single entity. Stability at home depends on coordination across healthcare, housing, transportation, nutrition, and caregiver support. Successful aging requires that the right services reach the right people at the right time. House Bill 278 strengthens Maryland's ability to plan responsibly for a growing aging population through cross-agency alignment and long-term strategy. It supports a structure in which organizations like Meals on Wheels of Central Maryland can help ensure that policy translates into measurable, real impact and ultimate cost savings. Community-based support is both humane and physically responsible. It costs just over $5,000 to serve an older adult for a year on Meals on Wheels, compared to more than $100,000 annually for nursing home care. In a recent study of participants in our Food Access and Support Services team, food insecure older adults demonstrated measurable reductions in healthcare utilization and cost after just 90 days of service. Maryland's aging population is growing. Coordinated planning and accountability today will determine whether older adults can age with dignity and stability in their homes now and into the future. For these reasons, we respectfully urge favorable consideration with amendments of House Bill 278. Thank you.
Yeah, that's good. Thank you, Madam Chair, members of the committee. My name is Ann Seacott, and I am here today representing the Maryland Area Agencies on Aging, M4A. They are the AAAs that serve all of your jurisdictions. We are here in proud support of House Bill 278. We absolutely support the codification of Longevity Ready Maryland. We are asking for one amendment, and we applaud the Secretary and the work of the department and stakeholders related to developing this multi-sector plan. We think it is important to codify it so that it continues into the future. We, to that extent, want to also offer an amendment that is related to including local plans. This administration has been doing so, and we believe that they will continue to. But as we are codifying this process to go on in the future, we want to make sure that the inclusion of local plans is a part of the statewide planning, because you all know that the differences in your jurisdictions need to be reflected at the state level as the state is responding to the growing aging population. Want to thank the department for acknowledging that we are in discussion, and hopefully we'll be nailing this down very soon. So with that, the AAAs want to express their support, and we urge you to do so.
Thank you very much for your testimony. Are there any questions from the members for these witnesses? Seeing none, thank you very much for your testimony, and this concludes this panel and also the bill hearing on House Bill 278. We will now be going to House Bill 367. That is health insurance, physical therapy, co-pays, co-insurance, and deductibles. Delegate Kipke, if you want to bring up your pen. Oh. He was here a moment ago. Hold, please. That's right, we're just going to take our time getting into our seats. Give Delegate Kipke a moment. Talk amongst yourselves. Don't make it awkward in any way. All right, Delegate Kipke, you can begin whenever you're ready.
House Bill 367, health insurance, physical therapy, co-payments, co-insurance, and deductibles is presented before you today. What this bill specifically would do is restrict the cost sharing for a patient to not exceed what they pay for a wellness visit. If any of you have been found out in your communities that you're a legislator on the health committee and they are a physical therapist, they have already contacted you over the years to express their concern of how individuals who are in need of physical therapy might avoid it because of their costs being much higher than what they would have to pay for a typical copay. I'll tell you, when I was 20, I had a back injury, and a particular type of provider was very eager to suggest that I get a certain surgery. And I'm very happy to tell you I avoided that surgery with physical therapy and had a full recovery. So I think it's important to acknowledge that physical therapy is a way to avoid much greater cost, both financial cost and also cost to an individual in the way of their long-term health. Many other states have taken action around this issue, so this would not be something that Maryland would be first in taking action. It's clearly a serious problem that needs to be addressed. It comes back every year. I'll acknowledge that the fiscal note is extremely high, but it counts the cost. It doesn't count the savings, as we all know, which is a persistent problem with many of our bills. And with that, I ask you for your thoughtful consideration of the bill, and thank you for your time today.
Good afternoon, Madam Chair, Vice Chair, and committee members. Thank you for the opportunity to speak in support of House Bill 367. My name is Dr. Linda Horn, and I'm the Director for Government Relations for the American Physical Therapy Association, Maryland. I've been a physical therapist for over 40 years, and I'm board certified in geriatrics and neurology. And while I'm a full-time faculty member at the University of Maryland in the Doctor of Physical Therapy program, I continue to treat adults who are at high risk of falling or who have fallen. We are in the midst of the silver tsunami, where 1 out of 6 adults in the United States are 65 and over, according to the 2020 census. And according to the Centers for Disease Control, 1 in 4 older adults fall every year, and this is likely low because they're afraid to report that they have fallen to their family and or their physicians. Additionally, 112 older adults die every day as a result of a fall. Research studies have shown that many falls can be prevented, and the key is to keep individuals moving. Many older adults need physical therapy to help them safely exercise. Physical therapists can determine what muscles are weak, assess balance, decide what exercises they need, and the need for an assistive device. And it's better to evaluate and treat people before they fall, maybe in their 50s and early 60s, or when they have chronic diseases and conditions. However, there are barriers to patients being able to attend physical therapy. Most of my career has been spent treating individuals in the Southwest Baltimore area, and they have shared with me that they are on a limited income and can't afford to come to physical therapy 2 to 3 times, not a week, but total. And most of my patients need more physical therapy to reduce fall risk. In 2023, the APTA released the economic value of physical therapy in the United States, and the average net savings is $2,144 per person. If copays were equal to the amount of annual wellness or physical visits, many patients may be able to access this need. While physical therapy is considered a specialist by insurers, I believe we should be in a separate category outside the physician category with a lower copay to improve access. I respectfully ask that the committee gives a favorable report to House Bill 367.
Good afternoon, Madam Chair and committee members. Thank you for the opportunity to speak in support of House Bill 367. My name is Rachel Rioli. I'm a physical therapist. I hold a PhD in rehabilitation science, and I'm a board-certified specialist in neurologic physical therapy. I also serve as the Vice President of the American Physical Therapy Association of Maryland, and I'm a full-time faculty member at the University of Maryland School of Medicine. As you just heard from Dr. Horn, our population is aging, and with that comes a growing number of falls. From a neurologic perspective, falls are not minor events. Individuals who fall are at a much higher risk for serious secondary injuries, including spinal cord injuries and traumatic brain injuries. These injuries can be life-altering for patients and incredibly costly to our healthcare system. These are not short-term problems. Often these injuries require surgery just to achieve medical stability, followed by months or longer of intensive rehabilitation. During that time, patients and their caregivers are frequently pulled away from work and daily responsibilities, adding to the financial and emotional strain. And these costs add up quickly, not just for families, but for the system as a whole. And the hard truth is, many of these injuries are preventable. Before I became a professor, I worked as a physical therapist for more than a decade. While working in an inpatient rehabilitation hospital, I treated an older adult who had sustained a fall and had a cervical spinal cord injury as a result of the fall. I remember this patient expressing deep regret that they had not followed through with outpatient therapy to address balance issues earlier. While they did not explicitly state cost was a barrier, I think we can all think of older adults in our lives for whom even modest copays make preventative care out of reach. House Bill 367 directly addresses this barrier. It shifts our system towards prevention rather than crisis care. It helps people access physical therapy before a fall occurs, before a life-changing injury, and before we incur greater cost. Maryland would not be alone in taking this step. To date, 13 states have passed similar legislation to limit the cost of copays. recognizing that prevention is both compassionate and physically responsible. Thank you for your time, and I respectfully ask for a favorable report on House Bill 367.
Good afternoon, Chair Bagnall, Vice Chair Cullison, members of the committee. I'm Dr. Roy Film. I'm a physical therapist with 30 years of experience. I'm a resident of Catonsville. I used to own a physical therapy practice in Ellicott City as well. I'm president of APTA Maryland today and also an assistant professor at the University of Maryland School of Medicine. My research focuses on how physical therapy can mitigate prescription opioid addiction and its associated costs. The cost analysis study conducted 4 years ago that was ordered by this body during the previous attempt in Maryland at passing similar legislation did not include a cost avoidance analysis, so it was not a true cost-benefit analysis at all. By assuming zero downstream savings, it ended up modeling a completely unrealistic fictional scenario, and of course it's going to look like there's a cost to it. Thankfully, we have quite a bit more data now from various states around the country. This legislation's passed in other states as well. And now, most recently, a few months ago, a large multi-state outpatient physical therapy claims-based analysis was published that showed that eliminating copays altogether, even still, leads to significant cost savings. It led to lower use of imaging, lower use of injections, surgery, and physician services. Since 2016, the World Health Organization and the CDC and several countries around the world have recommended non-drug therapies, including physical therapy, for first-line treatment recommendations for acute and chronic back pain, two of the most costly conditions. And by design, high PT copays create an artificial barrier that drives people away from cost-effective evidence-based care. Unfortunately, these policies disproportionately impact families of lower financial means as well. So they foster more chronic pain, they foster more surgeries, more injections, more opioid use, and ultimately more health inequity as well. Lowering PT copays isn't cherry picking. Physical therapy is evidence-based, cost-saving care. In addition to all the states that have passed this legislation recently, it's time for us to finally catch up. Thanks very much for the opportunity.
Madam Chair, Madam Vice Chair, I'm Dan Shattuck here today on behalf of APTA Maryland. You heard a lot of great testimony already. This is really a small sample of what the overall physical therapy community feels. This has been a big issue. It's been a barrier for their patients, and they're dedicated to eradicating it or changing it, opening the door to physical therapy. The health benefits are great. They're proven. We've got the studies. Since we were last here in 2002, 2 additional states have passed similar legislation, Ohio and West Virginia. Ohio as recently as 2025. There are 3 states currently looking at it in addition to Maryland, New York and Rhode Island and Texas. You're gonna hear from some additional physical therapists, but also some patients on the Zoom today. But then in your inbox, you're gonna be getting just some additional information with a little QR code. And that QR code's gonna take you to a little video, but some additional patient testimony. We didn't want to take up too much time today, but you'll hear it's from all over the state, patients who want access, who need this important service. And it's about recuperation, it's about recovery, it's about maintaining mobility, maintaining independence, maintaining your job, keeping yourself physically viable and active. It has mental health aspects. And when it comes to a choice to pay a copay for something that doctors prescribe frequently, healthcare providers prescribe frequently. If you're in a hospital, you're gonna get PT care after a stroke, after cardiac surgery. It's not just musculoskeletal. So there's a lot of implications. It impacts a broad number of patients. We're asking you, as our wonderful bill sponsor said, your thoughtful consideration. That let's not focus on the financial aspects as much as the benefits. On the fiscal note, I'll just add real quick, it does note the cost for the state retiree health plan. It's not mandatory that they abide by this except for Kaiser. I understand Kaiser's fully insured and this would apply to them, but again, that's more just a projection, not an absolute. Thank you.
Thank you, and we have one more virtual witness on this panel, Krista Frederick. You can begin your testimony when you're ready.
Thank you, Madam Chair, members of the committee. Thank you for the opportunity to testify in support of HB 367. My name is Krista Frederick. I'm a physical therapist with over 20 years of experience, and I own and manage 11 outpatient clinics serving more than 60,000 Maryland residents across multiple counties. I strongly agree with the testimony you've already heard from my colleagues. To avoid redundancy, I'd like to add a slightly different perspective based on what I've watched happen over the past 2 decades as cost sharing has steadily increased. During our previous consideration of similar legislation, the MHCC raised concerns that limiting PT cost sharing could lead to higher utilization and upward pressure on premiums, and I want to address that directly. Physical therapy utilization is not waste. As those of you who may have been a patient probably know, patients often joke that PT stands for pain and torture or physical torture. And while we try to make therapy positive, the reality is no one comes to physical therapy casually for convenience or fun. PT requires time off of work, transportation, childcare, energy, and real efforts. It's rarely the first choice of a patient. Patients come because they need their function back, and this is their best option to achieve that. Most stop as soon as they can return to their normal lives, frequently even before the provider believes they're ready. The real problem is not overuse, it's underuse. The MHCC report itself acknowledges that higher cost sharing leads to patients to postpone or discontinue care, which frequently results in greater long-term problems and health costs. Additionally, the previous MHCC report also suggested that PT parity may be inappropriate because primary care is more foundational and it may cause others to seek similar requests. But in Maryland, physical therapy is frontline musculoskeletal care. Maryland led the nation in 1979 as the first state to pass direct access, recognizing PT's role in direct primary care access for musculoskeletal conditions. And today, PTs can evaluate and treat patients without a physician referral. Over 40% of patients who come to my practice access physical therapy this way. With major shortages in primary care, PTs can help manage musculoskeletal problems early and efficiently and keep costs down, but only if patients can afford to access us early. The MSK Equip program that was begun in Maryland 2 years ago is also starting to demonstrate some of these downstream savings in the healthcare system as a result of management by physical therapy. HB 367 is a modest common sense fix. It does not eliminate cost sharing. It simply removes an unnecessary financial barrier to one of the highest value conservative treatments we have. I respectfully urge a favorable report on HB 367.
Thank you very much for your testimony. I'm going to open it up to questions. I have a question from Delegate Kaufman, followed by Delegate Johnson.
Yes, thank you. And I want to be fully transparent here and say that as a person with cerebral palsy, I greatly benefit from PT. But my question is for Delegate Kipke. We all have tremendous respect for our fiscal note writers and the work that they do. But do you think that that they sort of missed the boat in the sense that it did not encompass how much cheaper PT is as compared to more expensive interventions? You alluded to this in your testimony. I just wanted to give you a chance to put a finer point on it.
Yes, Delegate, I think that's how they analyze things. And because other states have acted, I think that we could learn from those states what the real life implications have been for their state-sponsored health insurance, for example. So I think there's some work to do around that that might better inform us as to what the outcome would be here in Maryland.
Thank you very much, Madam Chair. Thank you all for coming.
Delegate Johnson, followed by Delegate Hill.
Thank you, Madam Chair, and thank you for bringing the bill, Delegate. Mr. Film, Delegate Kipke had testified that he was able, through physical therapy, to avoid a surgery. So in your experience, do you find that the folks that come for physical therapy are often able to avoid a surgery, rarely able, or moderately able?
In my personal experience, in my own private practice, that was much more often the case than not. And many of those patients were already scheduled for spinal fusion surgeries, which range typically from about $80,000 to $150,000 of total costs. That would be over 1,000 visits of physical therapy. I mean, really, the savings are really potentially significant. No one goes to physical therapy for more than a few dozen sessions. So that's really pretty common. And if people are there, first they're there because they believe that this is possible, but if it's something that's not even a consideration because they can't afford it, there are so many barriers to pursuing physical therapy to begin with. Sometimes that high copay is really the proverbial nail in the coffin for their ability to even consider it. Copays, if after a surgery, there's still often physical therapy that orthopedic surgeons would recommend, and usually at a more aggressive rate, maybe 3 times a week for a couple months. At that kind of rate, the physical therapy copays add up to $500, $600, $700 per month. And at that rate, that's more than a car payment. And it's very easy to opt for opioids for a $10, $20 copayment per month. This is in a lot of expert publications about this, journal publications, they've referred to this as one of the primary drivers of the opioid crisis, in fact. So I would absolutely agree that it is something that physical therapy regularly helps with in terms of musculoskeletal elective types of surgeries.
Thank you. Thank you, Madam Chair.
Delegate Hill.
Thank you, Madam Chair. Delegate Kipke, thank you for the bill. I completely agree that physical therapy has great value. It's preventive. It's relatively low cost. My question has to do with the decision to have the legislation equate the copays to well visits, as opposed to some of the others. So we have different kinds of copays and cost sharing for surgeries and procedures than we do for well visits, different for hospital stays. And physical therapy is a procedural thing, right? It's not a simple visit generally. There are treatments, the billing is by time and by the visit itself, by particular treatment. So you put the cold packs on, there's something. If you do some stretching, it's something else. If you tape it, there's something else. So there's a whole combined thing. So I'm really curious about the decision to equate it to a well visit as opposed to saying there should be a copay for a diagnosis and bundle or series of treatments. So one copay, but you're going to need 3 treatments. I mean, it seems a little apples and oranges to me. So if you can help me understand how you're thinking about it, because I think we need to lower the barrier. I'm just not sure this one makes sense.
I'm not opposed to what you're suggesting. The idea is affordability, so that it doesn't prevent someone from getting a lower cost alternative to benefit their health. This is modeled after what most of the other places in the nation have done. There's a lot of attention around wellness visits to make them affordable because they're important. So I think that's the reason that it's selected. But I'm open to suggestions. Thank you.
All right, I'm seeing no other questions. We have to address the fiscal note, but I'm going to ask you to work with the department, work with our subcommittee, work with our members and see how we can get there, because I think there's clearly an appetite amongst this body. We know there's a problem, and we know that there is a return on that investment. So thank you very much to this panel. We have a favorable panel that is virtual. So if I can call Zishan Bimani and Nancy Erickson. And Mr. Bimani, you can get started when you're ready. Mr. Bimani, if you can unmute.
All right. Good afternoon, Madam Chair and members of the committee. My name is Zishan Bimani, and I've been a physical therapist for 11 years, working in different settings ranging from outpatient, skilled nursing, and home health. Currently, I work as a home health physical therapist in Montgomery County, and I'm also the Director of Reimbursement for APTA Maryland. I'm here to urge a favorable report for House Bill 367. Physical therapy is a cumulative process. We work in conjunction of the biological healing process, which requires multiple visits over time for it to be effective. Due to the current copay system, a $60 to $80 copay per visit cumulatively leads to an out-of-pocket barrier of approximately $600 per month for the patient. When the patient can't afford the dosage of the therapy, they end up skipping visits and or often stop treatment completely. For instance, I had a patient who came to our clinic with complaints of low back pain. He received a few sessions of therapy, but abruptly stopped, stating that his back pain was better and the high copays made it unaffordable for him to complete the recommended dosage. After a few months, that patient came back again, mentioning that he had aggravated his back pain, for which he had to go to the ER, get imaging, and finally a spinal injection, which helped him with pain for a few months, but it started wearing off. His orthopedic recommended to continue managing the pain with physical therapy. All this could have been avoided if the patient would have continued the recommended dosage and he would have had a better outcome. Studies show that PT management gives a net cost benefits of $4,160 for acute low back pain. This fair copay bill will not only help lowering the fee, but will also help patients choose a path which is replacing expensive surgeries and injections with proven conservative care. Thank you.
Thank you very much. Ms. Erickson, you can start when you're ready.
Thank you, Madam Chair. My name is Nancy Marks Erickson. I am a patient advocate. I was diagnosed with IBM, inclusion body myositis, 10 years ago. IBM is a rare, chronic, muscle-wasting disease that has no cure. Specialized physical therapy is our main form of treatment and is our medicine. For me and other patients with IBM, this requires multiple visits to certified physical therapists over extended periods of time. IBM without supervised exercise, muscles will waste away to the point where we can easily end up in wheelchairs. My PT insurance copays can easily be more than copays for my specialized physician visits. Perhaps some members or friends have experienced a heart attack. Once you experience that, treatment going forward is forever, unless you wish to stop living. We who have chronic diseases like IBM also need the ongoing treatment supervised by physical therapists as long as we live, and need to have the insurance cover our treatment without gouging us. I appreciate your favorable consideration of House Bill 367. Thank you.
Thank you very much for your testimony and for sharing your personal story. Are there any questions for this panel? Seeing none, thank you very much for your testimony today. We do have one unfavorable panel, so if I can ask Matt Celentano and Allison Taylor. You can get started when you're ready.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente. Start by saying Kaiser understands the value of physical therapy. We are a major employer of physical therapists in the state, and I'll say personally, I've had only wonderful experience with physical therapists in my personal life. Our opposition today is consistent with findings by the Maryland Healthcare Commission that recommended against passing this bill a couple of years ago. I'm gonna hit hit two of those points. First is that they note that lower cost sharing for primary care is the foundation of health insurance reforms under the Affordable Care Act. Lower cost sharing reflects the importance of primary care in promoting access and constraining costs. We do see this in light of that as opening the door to other specialties wanting to come in and be found to be equivalent with primary care. As you know, as I said, I think they do the Lord's work. There's lots of specialties out there that provide really critical services as well. In light of that, I will also say that. As many of you know, under the exchange, the individual small group on exchange plans are based on metal levels. And your metal level, gold, silver, or bronze, is determined by the actuarial value of the plan, so, which means the amount that the individual would expect to pay. And so, if you lower the cost sharing on physical therapy, in order to stay within that narrow band, you're going to have to raise it on something else. And so it is kind of a zero-sum game. I'd say pushing the balloon one direction goes the other, unfortunately. So those are our concerns, and happy to take questions.
Madam Chair, members of the Health Committee, I am Matt Celentano here today on behalf of the League of Life and Health Insurers in respectful opposition to House Bill 367. We're opposed because, first and foremost, physical therapists are specialists. Treating a specialist like a primary care physician is inappropriate, and it undermines the reimbursement and cost-sharing structure and design to encourage primary care visits, which carriers are begging the beneficiaries to do, for preventive usage and healthcare outcomes. We know that primary care and catching things early is better for outcomes and ultimately saving the healthcare system millions and millions of dollars. And carriers have designed that coverage along with ACA mandates, including metal levels with cost-sharing considerations to encourage that forward thinking. Well visits are $0. Sick visits are generally very low. Primary care is designed to be baked into your premium to encourage that healthy behavior. Having, physical therapists be lumped into this approach is inappropriate. Cost sharing is generally the same as any other specialist and should be treated like everyone else. Physical therapy is also not like a PCP well visit that you do every year. They're generally reoccurring and therefore require a different level of reimbursement, same as an oncologist. Once again, linking physical therapy to a primary care appointment is inappropriate. We can't start cherry picking specialists that want to reduce cost sharing for beneficiaries. We'd be here all day talking about which ones are the best ones and which ones are not. And it has the potential to bring the entire system and the pricing framework that keep premiums focused to a murky and really unpredictable place. So lastly, I would ask you all to refer to the MHCC study that was done after this bill was introduced in 2022. The commission said, quote, in a high functioning healthcare system, primary care providers are expected to provide patients with primary care comprehensiveness, first contact access, coordination, and continuity of care. Important as other services may be, they should not be given parity with primary care. We respectfully request an unfavorable report.
Thank you for your testimony. I'm looking for any questions from the committee. Delegate Hill, followed by Delegate Kazemi.
Thank you. Aye.
Aye.
Okay, so I agree with you, it's not primary care. But I think you also agree with Delegate Kippy that it's in many sense both treatment and preventive, right? So when I'm looking at, and let's just level set that when we're talking about cost sharing, we're talking about cost sharing based on what the insurance actually values the service as, not necessarily what's billed. So it could be a $400 bill from the provider, specialist, or whatever, and you guys decide it's worth $130. So the cost share is against what you guys decide the value is. Is that fair? Okay. So what I'm trying to look at is the percentage that the patient is asked to share for a relatively low-cost physical therapy visit versus, say, a visit to a reconstructive surgeon or orthopedic surgeon or a neurosurgeon, where they may still have a $50 copay, but for physical therapy, that might be a third of the cost of the visit, versus for the neurosurgeon, it might be a tenth of the cost. So I heard what you're saying. What I didn't hear is, here's an alternative way that we can look at it that actually encourages people to do the low-cost thing, like have physical therapy, that may save them the high-cost surgery.
Delegate Hill, can you
So
get
the
to your
question is, what alternative do you have?
It's a good question. I totally see your point on the cost of various services, which I think is what the proponents were making. I'd say short answer, I have to take that back, but happy to do so.
Fair enough.
Delegate Gazzoni.
Thank you, Madam Chair. When some of the earlier panelists were talking about that this is being done in a lot of other states, I did a quick Google and asked specifically because I was pretty sure that it was a zero copay for a primary care visit, like a well visit, annual kind of thing. And there are some states that have something, but not a lot. So I just want to sort of make sure that that was a little bit of apples and oranges.
Yeah, there are.
Not casting any aspersions, I get it.
No, Delegate, I appreciate that. And thank you for the opportunity. There are 0 states in the commercial market that have 0 cost share on wellness. No state has passed the bill as introduced that we see. There are some limited cost sharing for particular ailments that are treated by physical therapy in TRICARE, but not in the commercial market. There is no state that has 0 copay on physical therapy visits.
Thank you. Thank you, Madam.
All right, seeing no other questions, I think what I heard you say is that you were going to work with the bill sponsor and the subcommittee on a potential path that may not be this. Isn't that so?
I hear you loud and clear. That is so.
Thank you very much. This concludes the bill hearing on House Bill 376, and we are now going to move to House Bill 162. House Bill 162 is the Department of Aging Maryland Access Point Dementia-Friendly Communities. Delegate Queen, if you would like to step up and bring your panel, and you can get started whenever you're ready.
Okay, thank you. Thank you very much. I know you've had a long day. Okay, good afternoon, Chair Bagnall, Vice Chair Collison, and members of the Health Committee. I want to talk to you a little bit about HB 162, the dementia-friendly communities. Now, I don't typically come before you all, so this is sort of new, and I tend to deal with topics that are more in with my background and skill set. So this is a little bit different for me to be here to talk about this issue. But the impetus for this particular bill is occasionally when I attend various conferences and I hear people share their legislation and I listen to the topics and see how other states are doing things, that sometimes catches my eye. Other times it could be because I'm getting calls from constituents and they're saying, hey, I have this issue, I need information, and I find myself not knowing where to direct them or how to help them, so that also catches my eye. But sometimes it's just a lived experience, right? I experience something and then I say, okay, you know, how should we be doing that or how should that be handled? And so this is sort of the case for this bill. And so what drove me to this is I attended the Women in Government Conference over the summer, and I learned about the high prevalence of dementia in the U.S., but not only the high prevalence in the U.S., but what's the issue is here in Maryland. And Maryland is one of those states that seems to have a high prevalence of dementia. But not only that, I think it's about 13% of the residents who are 65 and older. But not only that, there are pockets in Maryland, Baltimore City, and Prince George's County who also experience high numbers of dementia. And so that was another issue that caught my eye. But the other thing that caught my eye is that by 2030, we should be having almost 1.3 million residents in Maryland who will be 65 and older. And I'll be part of that as well. So that also caught my eye. And so I was really concerned about this issue of dementia and what we can do about it. And so I started to kind of research, because I am a very data-driven person in the way I look at things. And I learned about something called U.S. aging and developing dementia-friendly communities, and Alzheimer's, looking at dementia-friendly dining, and this whole idea that you could have communities that come together that, I say it takes a village, that looks at the idea that people aging with dementia can live in the communities and be able to have resources available to them, and that we not have the stigma of dementia in those communities. And so this is the reason I'm looking at that. And so I was kind of looking also, again, if you look at the second page of my testimony, looking at the third page maybe, looking at the data that we have in our own Department of Aging as our outreach to people in the community that are 65 and older. And we have some goals where we are trying to help individuals live in the community, live in their communities, live at home. And what we projected in 2020, we reached over about 25,000 people. But in 2026, we're only estimating we'll be able to reach 18,000 people. That is a decline of 26% at a time when our population will be growing. And so I'm really worried about that. Are we going to be ready to support our aging community with the resources that they have and the resources that they will need to be able to live comfortably in our communities? And so that's the reason I brought this bill to play. And so I know that it has a fiscal note, but I'm really thinking when you hear from folks who are involved with this helping to serve individuals with dementia, you'll learn more ways that maybe we can tackle this with a less costly way. So I'm going to ask first, hopefully, if this will be okay with you, that you hear first from Gloria Lala, because she's one of us. She's a former senator, and she's also served as the Secretary of Aging. So she will have some good insights into what Maryland can do and what Maryland should do. Thank you.
Thank you very much. Good afternoon, Madam Chair, Madam Vice Chair, and members of the Health Committee. It's so good to be back home and see so many familiar faces. I am Gloria Lawler, former Secretary of Aging, and I'm urging you to please support passage of House Bill 162, which is the Department of Aging Maryland Access Point Dementia-Friendly Communities, sponsored by the Honorable Pam Queen. In 2015, Prince George's County Executive Rashawn Baker, in conjunction with the White House's Office on Aging, launched the Dementia Friendly America Initiative, DFAI for short. Prince George's County became one of the very first governmental entities nationally to establish a DFAI program. In the past 10 years, Prince George's County has developed a nationally recognized DFAI model, as well as we have encouraged and supported the establishment of DFAI in other Maryland communities and counties. House Bill 162 supports the establishment of a statewide supported Dementia-Friendly America Communities program within the Department of Aging's Maryland Access Point. Now, this would include all of the 19 AAAs.
It will provide the resources, training grants, and supports necessary to create and sustain dementia-friendly communities within each AAA local community-based efforts. Maryland families, seniors, caregivers, and Maryland's healthcare community will be among the many beneficiaries. Our state will prosper from this important action by you. Again, thank you for this opportunity to testify on this very important bill. I'm a senior. I'm looking forward to all of these services as I go toward my 9-0. I hope that. Thank you very much.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. I'm Flavia Walton, State Coordinator and Lead Trainer for Dementia Friendly Maryland. Dementia Friendly Maryland, led by volunteers, is part of the global movement Dementia Friends USA. It strives to introduce dementia friendly in every part of the state to equip Marylanders, young and seasoned, with information and strategies to understand, assist, and advocate for those impacted by dementia and become a dementia friend. Started in 2017, over 3,000 Marylanders have participated in free information sessions and have been trained in various venues to become dementia friends and champions. They're charged to help dispel stigmas and other obstacles that discourage and create barriers to understanding dementia in general and Alzheimer's specifically, which is the most prevalent type of all dementias. Equipping individuals with information and skills creates communities that are respectful, accommodating of individuals living with the disease as well as their care providers. By doing so, dementia-friendly communities are formed, information is shared, and soon a dementia-friendly state provides a healthier environment for individuals living with the disease, their families, and caregivers, making a difference in the lives of fellow citizens and increasing the quality of life for all Marylanders. Research demonstrates that individuals living with the disease do best when they are allowed to remain in their familiar environments that are accepting, respectful, and accommodating. We humbly request legislative support for this important program to expand the Dementia Friends Maryland program, to expand our reach and maximize the potential to reach our goal. A dementia-friendly state can offer reassurance to current Marylanders, residents who can be a magnet for potential residents looking for a friendly and accommodating place to live. Thank you so much.
Thank you all very much. I am going to start the questions before I go, because I want to make sure, Delegate, did you have an opportunity to see the letter from the Department of Aging?
I spoke with them. I didn't see all the specifics, but I know they talked about needing resources to kind of oversee this, and that they wanted to make sure the services were handled in the communities with their Maryland access point. And that's the intent of the bill. The difference I think we have is that, they already have the infrastructure there, and I don't know if they're leveraging the free resources and the information that Dementia Friendly America has that they could, better utilize.
I see. Because what they're saying is that they currently operate a long-term care and dementia navigation program. There's $2.4 million appropriated to this program. It's been in operation for just a year. They just have published their first report. Secretary Lawley, have you seen that report? Are you familiar with it?
I'm familiar with it, yes.
And can you help me understand what's different between this bill and the program we currently have?
I think what they need to do is to look at what the community-based effort in Dementia Friendly America brings to it and works through it. The resources are there within the department to do this.
So if I'm understanding correctly, then you believe that the Dementia Friends program
yes
has
additional resources that the state is not tapping into.
That's correct. Bring the two together.
Okay.
That is what we're asking them to do.
All right, I think I'm understanding. Thank you very much. I will go to Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate, for the bill. I'm looking on page 3 of the bill, line 25, and I just need some clarity. I'm not sure I understand. It says make physical environment safe, accessible, and easy to navigate through clear signage and accessible infrastructure. So on the physical side, what would be the accessible infrastructure? What is that?
So in some areas where we would have dementia-free communities, you would have, you could have signage in a restaurant that talks about we're a dementia-friendly restaurant where people have been trained. The signage is the same sort of signage you would have in any other sort of disabled or handicapped person. So it
Okay,
would.
I get the signage part.
Okay.
But it says and accessible infrastructure. That's the part I don't understand.
Go ahead.
We're looking at training people, example, training people, servers in restaurants. Often individuals with cognitive decline go to public places and are overwhelmed by all of the lights, the sound, et cetera. So we're training people to deal with those things, training them to deal with the individuals and the behaviors, but also to perhaps set aside times or tables or places specifically designed to accommodate individuals with those particular problems.
Okay, all right, thank you for the clarity. Thank you, Madam Chair.
We're witness. Dr. Walton, you were here for the discussion of the Longevity Ready Plan, and it looks like there are dementia-friendly programs similar to what's going on in Prince George's County and Baltimore City, Frederick, or Baltimore County, Frederick County, and Washington counties. So the question is, do you think that it would be a reasonable thing to either ask the department to incorporate many of the things you're asking for into the Longevity Ready Plan? Should that bill pass and that program be implemented? Or do you think that these things are best handled at the local level, and rather than the state program that the bill requests, we should be encouraging local jurisdictions to do more of the work that you're finding serves the constituency?
I think I'll defer to the expert on that one.
I think you're right, and that's what we are asking. You have the 19 AAAs. They're already there, and we are working in Prince George's through them and with them to do this. We are one model. We're asking for that to be considered to go statewide. It is very successful. We just want to be sure that Maryland becomes a dementia-friendly state and that people are not kept locked away. Also, it's going to impact your Medicare and Medicaid dollars. This is national. It's not something that's just sitting here in a couple of counties in Maryland. Because if people are able to live longer, more and independently, it saves Medicaid and Medicare dollars up in the millions.
Thank you.
What I may add to that, being out in the field, it also provides with the state kind of umbrella. It provides more cachet and more oomph behind the program.
Okay, thank you, thank you.
Thank you very much, and thank you, Madam Vice Chair. Seeing no other questions from our members, this concludes this panel and this hearing on House Bill 162. Thank you very much for your testimony.
Thank you.
Thank you.
And we are now going to move to House Bill 215, Continuing Care Providers, Financial Stress Tests, Transparency, and Governing Bodies. Delegate Vogel, if you want to bring your panel. Do we have Delegate Vogel? Do we have Delegate Vogel in the room? All right. Okay, do we have, yes, we do have Delegate Congola. So we're going to go to House Bill 393, which is Health Insurance Scalp Cooling Systems Required Coverage. Delegate Congola, if you want to come up and bring your panel.
Yes.
And you have 2 virtual witnesses on your panel, is that correct?
I believe so, yes.
You can come up and get started whenever you're ready.
Okay. Yep. Okay. So. And Madam Chair, just have a question. Would it be possible to have one of our people who are on online testify before a couple of people who are here in person? Would that be an
Sure,
issue?
you want to start with your virtual testimony?
Well, I want to start first, and then I have a line of folks that I want to
Absolutely.
testify.
We'll bring your virtual witnesses up
All right,
as
thank you so
part of this
much.
panel.
All right. All right, good afternoon, Madam Chair, Vice Chair, and members of the committee. For the record, I am Delegate Latoya Congola representing District 31, and I want to thank you for the opportunity for allowing me to present on House Bill 393. Chemotherapy saves lives, but for many patients, it also brings one of the most visible and emotionally distressing side effects imaginable, hair loss. For cancer patients, hair loss is not cosmetic. It is a public marker of illness that can deeply affect dignity, mental health, family life, and even employment. Scalp cooling systems are a proven, FDA-approved medical technology that reduces chemotherapy-induced hair loss by limiting blood flow to hair follicles during treatment. The Maryland Health Care Commission's review of clinical studies found that scalp cooling prevents significant hair loss in roughly 50 to over 80% of patients, with the highest effectiveness among patients with solid tumors. Despite the strong clinical evidence, scalp cooling remains out of reach for many Maryland patients because it is not covered by private insurance. Patients are often forced to pay between $1,000 and $3,000 out of pocket, creating a clear access gap that disproportionately affects low-income and underserved communities. For those who may not be familiar, I just want to go back to last year. We did present this bill last year. It was introduced, but it didn't pass because Maryland law required a cost analysis to determine the potential impact on health insurance premiums. So I'm happy to share that working with former Madam Chair, now Speaker Pena Melnick, her office was great in helping us coordinate the healthcare cost analysis. So I want to thank her and also the committee for working with us over the summer during that. So the analysis was completed in December of 25 and found that the cost impact is just pennies per month per member. In addition, the commission reported that the scalp cooling treatment is comparable to the cost of a prosthetic wig and reduces the overall health care cost of mental health treatment for cancer patients and their families. Supporting legislation for scalp cooling treatment is not just a matter of health care. It is a matter of compassion, equity, and empowerment. By passing this legislation, we will not only ease the emotional burden of cancer treatment, but also reaffirm our commitment to patient-centered care. New York and Louisiana passed a similar bill last year, and my goal is for Maryland to lead the way in being the next to follow suit. So I thank you all for your consideration, and I respectfully request a favorable report for HB 393.
Thank you very much, Delegate. And you said you want to bring up your virtual witnesses.
Yes, Madam Chair, thank you.
All right, so if we can bring up Karen Heggie and Melissa Boristom. And Ms. Heggie, you can get started. Do we have Karen Heggie? Okay. Let the record show we don't have Karen Heggie in the waiting room, but Melissa Boristom, you can go ahead and get started.
Super. Thank you very much. Good afternoon. My name is Melissa Borstam. I'm here today in support of House Bill 0393. I work for Paxman, manufacturer of the Paxman scalp cooling system that is used to administer this treatment. I've worked with scalp cooling devices for about 10 years and am honored to be here today with the strong and passionate patient advocates that you'll be hearing from. About 12% of patients will forego the prescribed life-saving chemotherapy due to fear of hair loss, highlighting the importance of access to scalp cooling for all. Scalp cooling is clinically accepted with a high degree of efficacy. Both ASCO and Medesco are strong supporters of its role in cancer care. And in 2022, the American Medical Association adopted a resolution endorsing insurance coverage. And this year, the service has been assigned Category 1 CPT codes. Scalp cooling is widely available. More than 900 cancer centers nationwide offer FDA-cleared devices, and 23 cancer centers in Maryland provide access, including both in-state NCI-designated comprehensive cancer centers, Johns Hopkins and University of Maryland. However, Maryland centers currently offer scalp cooling as cash pay only. They are not billing insurers, not because the technology lacks acceptance, but because insurance coverage is inconsistent and unpredictable. As a result, access to scalp cooling for Maryland patients is determined almost entirely by a patient's ability to pay out of pocket. The average cost to a patient for scalp cooling is approximately $2,500, while chemotherapy itself typically costs tens of thousands. This structure disproportionately impacts lower-income patients, exacerbating existing inequities in cancer care. Last month, legislative mandates for scalp cooling took effect in New York and Louisiana, and I'm happy to report to you that currently 10 additional states have pending legislative bills: California, Kentucky, Massachusetts, New Jersey, Ohio, Pennsylvania, Rhode Island, Virginia, and West Virginia. So we're thrilled to include Maryland in that list. House Bill 0393 represents a minimal overall cost increase to the state with limited impact on insurers, as the fiscal report showed. However, for patients, it removes a significant financial barrier and ensures they are not
if you can
forced
wrap
to
up your
choose
testimony.
between basic necessities and preserving quality of life during treatment. Thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you very much. And if I can ask you to stay on through the rest of the panel in case we have questions from the members.
And Madam Chair, I believe that Dr. Goldstein is also on.
Okay. They were on, but they logged off.
Okay, thank you.
So they may have had a conflict. Let the record show. Do we want to check one more time for Karen Hoogie? You can go ahead and proceed. Oh, we do have Dr. Goldstein. Dr. Goldstein, if you want to unmute, and you can proceed whenever you're ready.
Thank you. I'm Dr. Mark Goldstein. I'm an oncologist here in Maryland. I've been practicing since 2005, and I've been in Maryland since 2008. And I practice both hospital-based and private practice, currently at a private practice. And I'm currently the president of the State Oncology Society, Medesco, since January of 2025. I'm here to speak in support of this bill to support for insurance coverage for scalp cooling. As some of you know, my daughter was diagnosed with cancer over a year ago and received chemotherapy and lost all of her hair. And I can tell you, it's quite challenging and psychologically very traumatic for her and for us too, but especially for her. Most scalp cooling is available to women with diagnosis of breast cancer, but in fact, for several years it's been available for other patients as well with ovarian cancer and other types of cancer where they receive chemotherapy that can affect the hair. Scalp cooling has been around for a very long time, but the more refined technologies have been approved before 2018. But the problem is it's not available to everybody, and one of the reasons is cost. It can be fairly beneficial, and at least half the patients, they can have excellent results. But if the cost is a couple $1,000s, patients may choose not to do it. Some patients don't even know it exists, which is a separate issue, of course. CMS is now covering, and as of January 1st, 2026, New York, and I just found out Louisiana are now covering scalp cooling for these patients. I think that the technology, if it's more readily available and more cost effective, will be utilized more. And it's extremely important for patients' mental health and social well-being to be able to retain their hair if possible. And so for those reasons and others, I'm in favor of this bill.
Thank you very much for your testimony, and we wish your daughter very well and a full recovery. Thank you for sharing your story. You can go ahead and proceed.
And I believe Karen Hoffey is also in the waiting room to testify? No?
No, we called for Karen Hoffey, and we've not been able to locate her in the waiting room.
Okay. All right. Well, we'll proceed with our panel then. Thank you.
Good afternoon, Delegate Congolo, Madam Chair, and the House Health Committee. My name is Rosalind Ripper. Although currently in active treatment for HER2-positive breast cancer, I successfully completed 3 months of chemotherapy in May 2025. Through scalp cooling, I was able to keep all of my hair. I've spent the last year advocating for Marylanders to have access to scalp cooling and have it covered by insurance. Receiving a breast cancer diagnosis is a life-altering event. My initial thoughts were wondering if I was strong enough mentally and physically to get through cancer, if I could afford it, because even with health insurance, a cancer diagnosis is a financial burden. I worried about how I would maintain normalcy at my job and for my son. The most painful reality was that I was going to lose my hair. I was completely devastated. I learned that I would be a candidate for scalp cooling based on my chemo regimen and that I would have a chance to keep my hair. I wasn't prepared to learn that scalp cooling was not covered by my insurance and that I would have to pay for it myself. Fortunately, I was able to pay the $2,400 for the cost of my scalp cooling treatments. We as cancer patients go through so much. Being able to keep my hair during chemo through scalp cooling changed the trajectory of my overall cancer journey and made a meaningful difference in my life. It's not just about hair. Keeping your hair during chemo by using scalp cooling provides patients with hope and privacy. It allows one to maintain their identity and improves the mental well-being of those going through chemo. Now is the time to pass this meaningful legislation. We took the feedback offered from Field House 1187 and made necessary adjustments. As the delegate spoke to, the Maryland Health Care Commission submitted the mandate study, which showed no significant impacts to insurance companies and that it does improve the mental and social well-being of chemo patients. The American Medical Association has established CPT billing codes, which will allow for private medical institutions to bill insurance companies. So there is a pathway for the billing to insurance. And scalp cooling systems, like Melissa spoke about, are FDA cleared. In closing, scalp cooling is a game changer for those undergoing chemo. I am a beneficiary of that. My hope is that we can make scalp cooling accessible and affordable for all Marylanders. I respectfully ask that the House Health Committee pass this impactful legislation. Thank you, delegates, for your time.
Thank you for your testimony, and we're very glad that you are doing so well. We're also we have one person in the waiting room, but they haven't identified themselves, so we're trying to verify if that is your witness.
All right. Hello, my name is Kim Klasick, and I appreciate the opportunity to testify today in favor of House Bill 393, Scalp Cooling Systems. I am the midday host on WCBM, but that's like the side that most people see. I have run for Congress. I've been endorsed by the President Trump, and most importantly, I am a mom. Everything that I do today is truly a blessing, and I am here today in hopes to ensure blessings for others, especially young people that go through chemotherapy. When I was only 15 years old, a sophomore in high school, I lost all of my hair due to alopecia. I can truly testify that losing your hair due to no fault of your own can change your life. I do believe your physical appearance plays a large role in the choices that we make, and I ask that you support this nonpartisan bill to limit hair loss for anyone dealing with hair loss due to chemotherapy. I know hair may not seem like a big deal, but loss can lead to depression, stress, and harmful coping mechanisms. I know this personally, and I would never want to see anyone go through such a traumatic ordeal. I appreciate Delegate Latoya Congolo for the attention to this important matter that severely impacts mental health. I thank the co-sponsors and everyone that supported this across the aisle. I would like to also thank the insurance companies in advance for not taking on this minor cost without raising the cost of health care. And I can tell you that saving hair will save money in the long run. And to just reiterate how important it is for me to be here and testify in person, I walked here from the parking garage on icy cobblestone in my Jessica Simpson suede pumps, just to tell you how important this is to me. Thank you.
Thank you for your testimony and for sharing your personal story. We do have Karen Huffey. Would you like us to have your virtual witness?
Yes, please.
Ms. Huffey, welcome, and you can unmute and start your testimony. Ms. Huffey, you need to unmute. Ms. Huffey, can you hear us?
There we go. Is that better?
Yes, you can proceed with your testimony.
Okay, hi, my name is Karen Hoy. I'm an oncology nurse for almost 40 years, and we started using the cold cap about 5 or 6 years ago, maybe longer, when I was working at COHA. And I can tell you that it makes a huge difference for a patient. When someone's diagnosed with cancer, it's life-altering. And when you lose your hair, it is a daily reminder of why you lost it. And it's like putting an announcement on, I have cancer. You don't have to like your hair, but you still want to keep it. We tried to work with the insurance companies to get them to help pay. It did not work. We wrote letters of medical necessity. I think out of $400, one of them paid about $43. Hair is not an accessory. It is a part of your body. It's hard enough to go through cancer, but to have to lose your hair and have a daily reminder when it's something we can do to absolutely prevent it, it's wrong. The insurance company will pay for many, many things, but when it comes to our hair, they've forgotten it. This is a body part. It's not an accessory. So with our patients, and some patients, I also run a cancer support group, and some of my patients only learned about the Paxman from me. They've had chemo and were never told about hair loss. We're never told that they could prevent it. It goes so far, so far, when you can just watch somebody go through breast cancer, which 100% of the time you'll lose your hair, but to see a young person keep their hair, it's just amazing. I have a niece who was diagnosed at 31, and it cost her a small fortune. The day before her chemo, she started crying. She didn't want to lose her hair. And we found a way to provide money, and back then it was the cold cap, where the Paxman is so much easier. You don't need to buy the dry ice. You don't have to have someone put it on you. It works. You might lose maybe 20% of your hair, and 20% is a whole lot better than 100%. And unless you've gone through chemotherapy and lost your hair, you have no idea what it'll do to a person's, just to their whole self-being. When they keep their hair, they can keep their jobs. They feel better. When you lose your hair, it's like saying, I'm sick. Most people, if you see somebody in the store with a scarf, your first thought is, oh, they must have cancer. People don't want everyone to know.
Zoe, if you can wrap up your testimony, thank you.
Okay, I'm just hoping that you will make this bill passable. Men actually use it too. We've had many a man use the cold cap, but I just feel that women are underserved when it comes to insurance. And
Thank you very much, Ms. Hoey. And if I can ask you to remain on the line in case there are any questions at the end of this panel.
Thank you.
Thank you very much for your testimony.
Good afternoon. My name is Allison Rejick, and I live in Anne Arundel County. I'm here in support of House Bill 93, which would require insurance coverage for scalp cooling during the chemotherapy. 8 years ago, I underwent chemotherapy, radiation, and surgery for stage 2 HER2 positive breast cancer. During treatment, I used DigniCap to preserve my hair, and it was truly life-changing. Keeping my hair gave me the confidence to continue going into the office and working throughout my treatment. This helped me maintain a sense of normalcy during an incredibly frightening time. My survival mode at the time was to keep life as normal and uninterrupted as possible. As a mother of 2 young children, it is especially important for me that they didn't see their mom looking sick. Maintaining our routines and shielding them from fear helped me stay grounded. Scalp cooling played a critical role in that stability. It transformed a difficult journey into one that felt much more manageable. Unfortunately, scalp cooling wasn't covered by insurance and came with a significant out-of-pocket cost. I was fortunate enough to have family support, but many patients don't. I feel that no one should have to sacrifice well-being because of cost. I respectfully urge a favorable recommendation on this bill so that more cancer patients in Maryland can access and benefit from this meaningful therapy during treatment. Thank you.
Thank you very much for your testimony. Do I have a Dr. Kashina Cross?
Yep. Okay.
Thank you. Good afternoon, Madam Chair, Madam Vice Chair, members of this esteemed committee. I am Dr. Kashina Cross, and I am a local legislative leader here in the state of Maryland, representing not only the strong support of many members of our community who unfortunately have to deal with cancer, look at cancer. We don't have to look how we feel, though. I support House Bill 393 with its compassion, and I also supported Senate Bill 272 yesterday with its direct intent. Right here, we are advancing medical science. Patients receiving world-class cancer care are treated not only by oncologists, but these are surgeons, radiological specialists who are working together with one piece in mind, which is the peace of mind of those that they serve. We are in a fight. This is a common fight. These are rare cancers, but they're also utilizing chemotherapy. These are targeted therapies. We're talking about modern medicine. We're on the breaking barrier of understanding care, not undermining patients. Patients who go through chemotherapy need this scalp cooling. It works. We have provided the evidence. The basis are 60 to 90% of patients retain their hair. And it is not an apparatus. It is your identity. Anybody ever had a bad haircut? I have. It took me 2.5 years, 3 months of crying in the mirror, and 5 months after that to recover mentally from what I could not see anymore, which was myself. You cannot imagine to see the sprigs blowing in the wind and acknowledge that $2,500 was the difference between your self-care and your humanity. Many people do not see this as an experiment. This is modern medicine. We today, patients and facilities alike, are asking for you, Marylanders, to stand up and be the 3rd state in the nation to do this, and we can do this. We cannot ignore it. We bought it here last year, and House Bill 1187, we come back this year. The identity was not lost. The emotional distress has collided. I highly encourage you to support this Senate bill, House Bill 393.
Thank you very much for your really impassioned testimony and for all of you for sharing your stories today. Do we have questions from the committee? I have Delegate Ross followed by Delegate Hutchinson.
Madam Chair, will this bill, if passed, will it be retroactively applied to claims that have already been submitted pending payment within the last year?
No, the goal is for this to be effective January 1 of 2027.
Okay, so if a claim is already, say it's January 20, like last month, and they've already submitted it, but it hasn't, it's pending payment right now. So could they resubmit it with an adjustment?
No, they cannot.
It's unfortunate. Yeah, this is a great bill. And, you know, the medically necessary piece, is there some universally accepted definition of medically necessary to your knowledge?
Ooh, I'll have to defer to my colleagues here or panel. I see Melissa has her hand raised.
I do. I was going to address the when this would take effect part. So, of course, as you said, this would take effect January 1st. However, patients that are already undergoing chemotherapy, so let's say you start December 15th, typically chemo is several months long. So it may be that they incur costs in 2026, but once January 1st hits, anything they incur after that, would be covered. So, and in terms of what is medically necessary, I mean, I think the best way to think about that is it just is referring to any healthcare services that is aligned with generally accepted standards of medicine. So it's not experimental. It's, provided in an appropriate setting. In the case of insurance, that means, in effect, it's charted, they have documentation, but often payers request a letter of medical necessity stating that this is something that the doctor wants the patient to do.
Okay. Yes, thank you. And I only asked that question to check that box for the one or two people in the world who don't understand the importance of this.
Absolutely.
Great, Bill.
Thank you for asking.
Delegate Hutchinson.
Thank you, Madam Chair, and thank you for calling on Delegate Ross first, so that I had a moment to collect my thoughts. This is a very emotional bill for me, actually, and I wanted to be here today for this, and I'm sorry I was late getting here. Having been the husband that stood in the shower with the razor to shave off the very last bit of hair that was left is a memory that is really hard for me to get out of my mind. So there's not only the patient that's affected by this, but there's always the loved one or the spouse that's there as a part of that. I haven't had a chance to look through it. I see that Matt wrote a letter. He's not here testifying. Where does the insurance stand on this? And the other is, how much does this cost? I'd be curious.
Yeah, so we did the cost analysis, and obviously I wanted to take a very fiscally responsible approach to implementing this bill. So what we're seeing is that what the analysis shows that it's pretty much pennies on a dollar. I think it said on average it would cost maybe $951 for the treatment itself. But the other thing that we want to keep in mind too is that this costs no more than the prosthetic wig, and it in fact can be cheaper than the wig. And most women would prefer to preserve their own hair than to be prescribed a prosthetic wig. The other thing that the analysis did show is that the healthcare costs, mental health care costs, like you said, you being the spouse of a survivor or someone going through chemotherapy, families have been traumatized. Families have been mentally and emotionally impacted, and saving dollars on mental health therapy is another advantage to this bill being passed.
Great. Well, thank you for bringing the bill. Good luck.
And thank you for sharing your story. And these are stories that I've heard for the past year from many people on a regular basis, so thank you.
Okay. Seeing no further questions, I just want to say thank you for doing your due diligence during the interim, because it makes a huge difference. And I want to thank all of you for sharing your stories, and we wish, this entire committee wishes you good health and many, many blessings, because it makes a difference. And I know it's hard to come out here and share these very personal stories. So thank you. Thank you for your time, and thank you for your advocacy.
Okay, thank you, and thank you, committee members.
Thank you.
This concludes House Bill 393. We are going to move on to House Bill 215. That is continuing care providers, financial stress tests, transparency, and governing bodies. I also want to thank our members for sharing their personal stories as well.
Thank you, Madam Chair, Madam Vice Chair. Here with House Bill 215, which focuses on financial stress tests, transparency, and the governing bodies of our continuing care retirement communities. So in the past, the General Assembly has passed legislation requiring representation of residents of CCRCs. I'm sure many of you have CCRCs in your own communities to serve on the governing bodies of the businesses of the CCRC. The reason this is important, and I've heard from my constituents who have shared their personal stories. I visited in just the last year 3 different CCRCs in my district, and this is the leading issue that every resident shares with me as soon as I walk in the door. And the reason is, these residents are making significant financial investments, right? The structure of the way that a CCRC works, as I'm sure you all know, is you're paying upwards of $500,000, $750,000, maybe even more, depending on the CCRC you're living in, money that you will never see back, right? You will never see that money again. You're paying it. It's a one-time payment, and then you're paying a monthly or yearly, depending on the CCRC rate on top of that. So there is a really significant it is a very significant financial investment that residents are making, and that's why the financial transparency, the financial integrity of the institutions is so vital. If a CCRC collapses, if they go under, all of those residents, their personal finances are tied to the sustainability of that continuing care retirement community. And on top of that, right, given that they really can't leave, they want to have a voice in the decisions that are made, not only to ensure that they are having great quality of life and a great experience at the retirement community, but also to make sure that the decisions that are made are in the best interest of the residents. The issue that we're seeing with that representative on the governing body is that in the case of my constituents, they have a representative. I represent this CCRC called Asbury. So Asbury has a representative on a governing body. It is not, however, the governing body where the decisions are actually made. Asbury Atlantic is where they have their representative. On top of Asbury Atlantic is Asbury Communities. Asbury Communities is the governing board with all the power. And the board of directors of Asbury Communities has the powers including approval of any merger, closure, sale, lease, or exchange of any assets, the approval of the budget of the corporation, both operating and capital, the authority and responsibility to approve any proposed project for the development of a new product in our facility by the corporation. So essentially what we're talking about here is it was the intent of the General Assembly to make sure that there is a resident at the level where the decisions are being made. What we're now seeing is there was a lower governing body essentially created where that's where the representative is, but that's not the governing board that has the power, right? Which gives real concerns to the residents that want to have their voices heard. The bill also requires a few additional things, and I know that we've been back and forth with the Department of Aging on this. There's a desire to have greater transparency over the finances of the CCRC. A proposal that we laid out was to give a grade to the financial stability on the financial stability of the CCRC. There was some concern around how that could potentially lead to litigation, and I recognize those concerns, and I'm willing to work with the committee to make sure that we are allowing for as much transparency as possible while addressing the concerns of the Department of Health. And what we're also asking for here is for the ownership of the CCRC, for these governing boards to have a greater presence within the resident community. We're all delegates. We would not be able to do our job of best serving our constituents if we were not showing up in the communities that we represent. There needs to be a greater obligation for the governing boards, for the leadership of these CCRCs. Last I checked, the CEO of the CCRC that I represent makes over $1 million a year, right? We need to make sure that those people that are doing this work, that are earning these salaries, are actually showing up and meeting with the residents that they serve. And lastly, I believe in democracy. I believe in elections. I think that the members of the representatives on these governing bodies should be elected. I think there is a massive conflict of interest that is created if those representatives on the governing body are selected by the people on the governing body, right? That is not fair, and that is not the type of representation that we would like to see in the intent, I believe, of the General Assembly when these requirements were put in place. I respectfully ask for a favorable report on House Bill 215.
All right, we're going to open it up to questions from the members. Delegate Kaufman, followed by Delegate Morgan.
Yes, thank you. Can you hear me?
Loud and clear.
It says, the Department of Aging, I'm going to read you a sentence from their opposition testimony, and I want to know what your response is. It says, as drafted, the bill raises concerns regarding resource constraints, duplicative oversight, public misinterpretation of financial data, and unintended consequences for providers and residents. And they also say it will create new operational, fiscal, and legal responsibilities on the department. So what is your response to their concerns?
Thank you, Delegate. So we've had meetings with the Department of Health on this, or sorry, the Department of Aging. So the way that what the bill requires is a number of things. One is for there to be a financial stress test conducted on the CCRC, right? This is asking a series of different questions related to, the occupancy rates, which there's serious concerns about in the CCRC that I represent. If you have a very low occupancy rate, that could lead to some real financial problems for the CCRC, the net operating margins, liquidity, capital structure, debt service. That should all be, I believe, and I'm going to continue talking with the Department of Aging. I hope that's all being considered in their assessments of the CCRCs, which I believe they conduct annually. I want to make sure those assessments are as strong as possible. Where the concern, my understanding is that there really is great concern is around giving a letter grade. I understand that could be a bit arbitrary, right, of whether a CCRC gets, whether their finances get an A or an A plus or a B or a B minus. So if we want to remove that from the bill, I'm open to that. I just want to see two things. One is to make sure the financial stress tests are important to make sure that these CCRCs are in good financial standing, number one, but also there has to be transparency, because if you're investing your life savings to live the rest of your life in a retirement community, you need to know that that investment is you're investing in a business that is financially sound, and residents deserve to have that information and deserve to have a voice in making the decisions that determine whether or not that CCRC is financially sound.
Thank you, Madam Chair.
Thank you. Delegate Morgan, followed by Delegate Taveras.
Thank you. Thank you, Madam Chair. You just, I think, answered one of my questions, Delegate, because I was chuckling a little bit because state government, I mean, we've raised $2 billion of taxes. We have a $1.4 billion deficit. We just had a credit downgrade. I'm like, man, I don't think anybody in state government should be judging the financial stability of a private industry. I would be shocked to give them a letter grade, but you're okay with removing that portion or something?
Sure. Look, I'm advocating for my residents at the CCRCs I represent who are concerned about the financial. Every time I walk in there, their biggest concern is the financial stability of their CCRC. That seems a little out of scope with what we're talking about here, but I see the point you're trying to make.
Yeah. Little tongue-in-cheek on that. But my question is, you talked about the elected person on the board, and I thought that was kind of interesting because you have the business side of the CCRC, and then if you were electing a resident on there, could you see a situation where if those two were in conflict, who would be determined to be the right way, the right path to go? The elected person or the people mandated on the board by the CCRC, which is a private business?
So Delegate, I think two things. One, it's a fundamental question, I think, of what is a CCRC? What is a retirement community, and who are they intended to serve? If the purpose of it is to generate as much profit as possible, then sure, like that might be a fair point. But you have thousands of my constituents that are living in these retirement communities that deserve a great quality of life and deserve to know that the investments that they made are in an institution that is financially sound. That is my leading concern, and that's why I think that they deserve to have adequate representation on the governing board. They're also not going to be the majority of the governing board, right? So the business still has a significant power with, to appoint other folks on that governing board. We're just asking for one person to be on the governing board where the decisions are actually being made and not on, some secondary board that doesn't actually have the full powers.
Okay, appreciate it.
Thank you,
for the
Delegate.
answer. Thank you, Madam Chair.
Delegate Taveras.
Thank you, Madam Chair. Thank you. I was trying to remember who was the, I just remember him as Tim, who was responsible for creating the stress test for banks post the housing bubble bursting. But I'll be frank, I like the idea. I think, and it seems sort of necessary. My question is, that when you look, this is a structure that seems very similar to condominiums. And we haven't really done a great job because a lot of the people that go on that are elected are not experienced to manage. So how do you account for that?
Yep, thank you, Delegate. I think on your first point, if we start having CCRCs go down, and we're seeing, there are CCRCs that are in very difficult financial situations, we're going to have a crisis in our state. Because the way that these work, right, you're not getting that money back. If you're spending $500,000, as a joining fee for joining a CCRC, like that's not refundable. Like they're keeping that, right? Even if you pass away, like they're keeping that money. So what are we, if they start collapsing because of poor finances, what are we going to do with all these residents that live in these retirement communities? So the need for these to be financially sound and for there to be adequate stress tests is of utmost importance. The difference that I see between condos and CCRCs is the point that I just made, right? You can always leave a condo, sell your condo and leave. You can't do that with a retirement community. You're there, you're stuck, right? So that's, I think, a really important point. And then on your question around experience for those in the governing bodies, I've been working with residents of mine on these, on this legislation, former ambassadors, former high-level attorneys, right? Financial experts, right? Folks that really have the preparation, not just be working on this bill, but to be adequately representing their neighbors on a CCRC governing board. I think I trust the way that I trust the voters to send all of us here. I trust the residents to elect the right people to their governing boards.
Have a quick follow-up?
I need to clarify the record for a moment, and then you can have a follow-up. Because I just want to make clear, as we're having this conversation, that this is not a condo. This is not an HOA. This is actually a long-term insurance product.
Yep.
And we need to be looking at legislation through the lens of a long-term insurance product, not through an HOA or a condo.
Absolutely.
Thank you. Delegate Taveras.
No, thank you. Thank you for that clarification. Okay, well, then as a long-term insurance product, you can change insurance companies. Why are you not allowed to change this insurance product to move into another one and have it be prorated? I think that there's an issue, like you said. Through this CRC.
And I believe that there will be another mechanism.
Okay. Well, thank you.
Thank you, Delegate.
Delegate Shalega, followed by Delegate Gazzoni.
Thank you, Madam Chair. Good to see you.
Good to see you again, Delegate.
Been a half hour, I think. A CCRC is nothing like a condo. My parents live in a CCRC. My grandparents lived in one. I'd like to live in one day. So, let's make sure we keep these alive.
Yep.
Have you heard the saying, if you've seen one CCRC, you've seen one CCRC?
Sure, yes.
And why would-
First time hearing it now, though.
Why would people say that?
They're all different.
Exactly. And the contracts are all different.
Mm-hmm.
And it is a long-term care insurance.
Yes.
It is not a condo. It's not an apartment.
Absolutely.
Okay. And of course, we want to make sure they're economically viable, financially viable. So in the bill I'm reading, it says, after reviewing a financial stress test report prepared in accordance with this section, the department's financial review committee shall assign a grade. So, doesn't the Department of Aging already do this?
They don't assign a grade, Delegate.
So who's going to make the grade up?
So, this is what we were discussing earlier with, I think it was Delegate Kaufman that raised that question. And I heard the concerns from the Department of Aging, and I would fully support an amendment to just require the financial stress test and transparency around the stress test, but not assign a grade.
Okay. Thank you.
Vice Chair Cullison.
Thank you, Madam Chair. Delegate Vogel, are you aware, I think it was 2 years ago, Delegate Stein and I worked on the bill that provided the representation on the board?
Yes.
And the Resident Association was fully on board with that.
Yes.
And they agreed that the representative needed to be on the board that was making decisions for their CCRC, and that had to do with their daily living and, what the amenities were and how they were doing. So they were happy with that 2 years ago, and I haven't heard from them since. But the question I have is, have you visited a CCRC with representatives of the board of the CCRC and residents and talked through how it works at that one CCRC that you're seeing?
Yes. So I have visited 3 CCRCs in my district. I have met with the CEO of Asbury Communities. I have spent time with representatives from Leading Age and other industry groups, both on-site and in virtual conversations over the course of the last year and a half. On your first point, though, Delegate, if I may, Vice Chair, if I may, this is every time I walk into a CCRC, I had 3 town halls in the 3 different CCRCs with large groups of constituents. This is their leading concern, is around their spot on the governing body. It might be because, to Delegate Schlegel's point, every CCRC is unique, and some of them have been, maybe skirting our intention in different ways. But, Asbury Communities is a very large organization, and they're making investments across not just in the retirement space, but in other industry spaces as well, which has my constituents very concerned about what happens if all of Asbury Communities goes down. Are they somehow implicated in that as well? And does that put them in a financially challenging position, right? Does Asbury Village and Gaithersburg go down because the entire organization is going down? And these are the concerns that I've heard from attorneys and financial experts who are my constituents who live in the CCRC. And I think there's this frustration that they would like to have that representative on the governing board, but sure, it might be the one that's most closely determining what life looks like in their community, but it's not the board that is determining the financial decisions that could make or break the institution as a whole.
Okay.
Thank you. I'm going to ask a question because you mentioned that you had been working with Lifespan and Leading Age. Have you availed yourself of their expertise in response to this proposed legislation?
So I met with Leading Age representatives a year and a half ago on site at one of the CCRCs. And we had probably a 2-hour conversation followed by a tour. As a follow-up to that, I had a meeting one-on-one with the CEO of Asbury Communities. Then, I had some clarity as to what the issues were. I went back to my constituents the next year and heard just a larger and larger crowd expressing their concern and frustration around this. And I've made this we had a conversation just last week with, I know they're back there somewhere, where we discussed this issue. And I made clear, this might be part of it might be a communication issue between the CCRC ownership and the governing body and their residents. And that's something that I can't solve, right? I'm trying to, with this, create a greater degree of transparency and requirements around them having a greater presence. But when you start having a larger and larger and larger number of constituents raise this as a concern, to me, that's a signal that something is wrong. And, I'm happy to continue working with them on the specifics, the same way that we've worked with the Department of Aging to address concerns around the grading, and we've made necessary adjustments. What I struggle with, right, is that some things have to change. And if the answer to this is we don't want any of this, then I think we have some disagreement with the industry groups.
Thank you. Delegate Hill.
Thank you. Thank you, Delegate Vogel. So there are really two parts to your bill, as I understand it. There's a stress test, and then there's the board, right?
Yes.
And the residents think of this like an investment, and the people managing it seeing it like a long-term insurance policy, right? So we've dealt with some of the board, maybe not to the satisfaction of your constituents, but can you separate those two if we were to do something with the stress test piece and not do the board piece? Is that a direction?
Absolutely. I think that's a helpful step, Delegate. I think the reason that it's a two-step approach is because, one, there's a desire to see what the financial situation is within these CCRCs at this present moment. But there are decisions, even with that information, there's a decision that could be made tomorrow by one of the governing bodies. In the case of my constituents, it wouldn't be at the level where they have a representative. It would be a level above that. But the decisions that are made at that level within that governing body then have a consequence for them as well, right? So that's why they want to be having representation of the decision where those financial decisions are made.
Can I follow? Thank you. So if we do the stress test and it's found that they don't have sufficient reserves, then generally the option is to go back to the residents and change their contracts, which the residents generally don't want to do. They've come in under a promise that this is how much they can pay. So the only option then is future residents will get a different, just like a long-term care insurance, if the insurer has underfunded based on actuarial projections.
Delegate, can you ask your
right?
question?
So that still leads to more frustration because it's not going to resolve the problem for the residents that are there.
Yeah, I think that there's a complex number of, there's a number of different complex financial decisions that CCRCs can make, especially one like Asbury Communities that is investing in, I heard last year in my conversations, both with constituents and with the ownership, the governing body, right? The CEO in this case, and their representatives that, they invested, for example, in like a technology company, right? That there might be some connection, right, to seniors and to retirees, and that's why they're making those investments. But there's decisions that are being made all the time as to the investments that are being made without anyone representing the needs and the desires of the residents, right? So those decisions could have financial implications, do have financial implications, which is why I think it's important that they at least have greater insight into what's happening in the form of, ideally, a representative, elected representative at the highest level of the governing body.
All right, thank you, Madam Chairman, for your indulgence.
Thank you very much. Seeing no further questions, this concludes this panel. Thank you very much for your testimony and for your concern. And we're going to bring up an unfavorable panel: Allison Siborowski, Michelle Rosenheim, Elizabeth Legenhausen, and Dana Kaufman. And you can get started with your testimony.
Thank you. Thank you, Madam Chair, Madam Vice Chair, members of the committee. My name is Allison Siborowski, here today again on behalf of Leading Age Maryland. And I'm joined today by Miss Betty Legenhausen, who is a resident and a board member at Broadmead, which is a CCRC in Hunt Valley, Maryland, and by Michelle Rosenheim, who is on the leadership team with Lutheran Social Ministries of Maryland. And so they will have some great insights to share with you all about the inner workings of CCRCs from both the resident and the provider perspective. I wanted to just make a couple of notes. I am respectfully requesting an unfavorable report on House Bill 215. And one of the reasons is that we have worked very closely with this committee and with HGO and its previous iterations and with MACRA to compromise and come to an understanding on legislation the past 2 years. One of those bills just went into effect January 1st of this year, so it's been about 30 days. And so we would urge that the committee take a close look at the changes that we have, both sides have come to compromise and agree on over the past 2 years and allow those changes to take effect. I wanted to note just a couple of items that I respectfully see as inaccuracies in what was described previously in the bill. First of all, the sponsor noted that his bill requires corporate boards of directors to include CCRC residents. However, that's not how the bill reads. Instead, it ensures that the residents who serve on the governing body have the same rights and responsibilities as other board members, which is already enshrined in Maryland law. And as I noted, one of the changes that went into effect just in January was requiring an alternate on a board of directors as well, a resident alternate member. I also wanted to note just a couple of things that the sponsor noted. He noted that these refunds are not refundable, and in fact, they are refundable. Residents can choose what type of a contract they want, if they want it to be refundable or not. Also, residents can most definitely move from one CCRC and go to another. It's all resident choice. You pick the contract, you pick the terms, and so I know that Michelle can speak further to that. This is certainly not something where you have to be locked in for life. It's all what the resident chooses when they move in terms of what terms they want and what's going to work for them. So lastly, I just want to note that, again, we really compromised, came to the table in good faith the last 2 years. Let's let those changes take effect. Thank you, and for these reasons, we respectfully ask for an unfavorable report on House Bill 215. And I'm going to pass it next to Dana Kaufman.
Oh, thought I was going last. For the record, my name is Dana Kaufman. I'm here on behalf of Lifespan Network, and I think I want to narrow my testimony to two things. First of all, when we talk about the financial strength of the CCRCs, I do not want you leaving here thinking that that is not looked at. That is looked at every single year. I put a link on a footnote in my testimony, and that is every year the providers have to apply for a renewal of their certification. And as part of that renewal, they are having to submit a certified financial statement, operating budget, projected operating budget, actuarial study. The list goes on. And all of that information is looked at by the Department of Aging. If the Department of Aging thinks that there is an issue, they send it to an independent financial review committee, which has consumers, preferably subscribers. That is part of the regulations. And then that financial committee does its overview and then sends it back to the department with its recommendations. So to a certain extent, the stress test is already being done, and it's being done every year. So it's not necessary to include that and have another 2 independent individuals hired by the department, especially given the fiscal situation that we're under. So that is the one comment I wanted to make. The second comment is, and it may have been in last year, but I think it was in 2024, there was a lot of concerns about just transparency and disclosure. So this committee, and we agreed, changed the requirement that the providers had to meet not annually with all the subscribers, but quarterly. and we've been doing that. But this bill actually limits the communication because now instead of meeting quarterly with all of those subscribers, you only have to meet quarterly with the Residents Association, and then the provider can decide whether or not to open it all up to everyone else. So I'm not even sure why we would want to limit communication to all subscribers. So those are the two issues I wanted to point out, and we would request an unfavorable. Thank you.
You want to go next?
Good afternoon, Madam Chair Bagnall, Madam Vice Chair Cullison, and members of the House Health Committee. As Allison stated, my name is Michelle Rosenheim, and I serve as Vice President of Operation for Lutheran Social Ministries of Maryland. We operate two CCRCs in Maryland, serving almost 1,000 residents. I'm here today in opposition to House Bill 215. As many have mentioned, within CCRCs, residents are meaningfully engaged in governance and maintain an ongoing collaborative relationship with leadership. Regulations already require residents to provide input regarding resident-elected board members. It also should be noted that they are voting members of the board, which in fact vote on things like the budget and receive annual presentations of the audit. At communities, executive directors meet with residents often monthly and with councils as well as associations, which serve as a collective voice of the residents we serve. Leadership collaborates closely with resident committees, provide frequent updates, and ensure residents have access to board minutes. Current regulations, as Dinah mentioned, already require 4 quarterly meetings with authorized officers to review financial and operational updates. To give you an examples of what we do, it's budget, typically it's the audit, and currently we are doing a mid-year financial update. Importantly, Maryland already has formal grievance procedures, including third-party mediation, and all grievances are in fact reported to the Department of Aging. We're also required to receive resident feedback at least annually, and in looking at the majority of CCRCs, you will note that the overwhelming majority of residents are satisfied. Allowing non-qualified board members to be elected without appropriate safeguard creates a risk that individual interests could outweigh the collective interest of all residents and the long-term viability of the community. For these reasons, I respect an unfavorable report on House Bill 215. Thank you for your time.
Good afternoon, everyone. Good afternoon. My name is Elizabeth Legenhausen. Thank you so much for having me here. I am one of the Silver Cyclone. I am a resident of Broadmead, and I have been for 5 years, and it's my perfect delight to be able to be before you today. To see democracy in action has been a capstone for me, so thank you. It is kind of fascinating for me to listen to Delegate Vogel's passion, and I admire it. And I think that there is lots of compromise coming ahead. Broadmead is one of the first CCRCs in the state of Maryland. It was founded in 1979. Currently, the Broadmead community, founded on Quaker values, consists of over 400 independent and assisted living residents, 270 plus team members, and a very enviable occupancy rate, nearly full. I've resided at Broadmead for 5 years, and the last 2 years as a member of the Broadmead Board of Trustees, the highest level of decision-making that exists at Broadmead. I'm also on the Finance Committee of the board, the Executive Evaluation and Compensation Committee, and the Strategic Planning Committee. I've served throughout my career on nonprofit independent school boards as a head of school. Furthermore, as Director of Accreditation for the Association of Independent Maryland and DC Schools, I have collaborated confidentially with member schools, of which there were 120, to do stress tests, at the end of which saved those schools. So there is value in that without a doubt, but the idea of ranking schools is anathema to anything that I believe about CCRCs or schools. For these reasons and others that have already been described absolutely beautifully, I respectfully request an unfavorable report on HB 215. Thank you.
Seeing none. Oh, I'm sorry, Delegate Schlegel. I think you snuck that in. Go ahead.
Thank you, Madam Vice Chair. Thanks for being here. Mrs. Liggenhausen, thanks for being here. I represent Oak Crest. So I think it's the largest CCRC in the state. My mom lives at Ginger Cove, right around the corner here. So the macro group at Oak Crest is very active. They're coming, are you coming next week or the week after? They're doing a big macro group.
22nd, I think.
Yeah, so I look forward to seeing them. And they haven't mentioned this to me at all, so I don't think it's one of their priorities. So I guess my question would be for whomever one person wants to take this. Could this be accomplished? I understand Delegate Vogel's concern. You know, he has some folks in his CCRC that are concerned. Could some of their concerns be addressed through contractual means, or, you know, instead of putting in a bill that affects everyone, you know, how could the residents go to that, you know, particular overriding group, which obviously doesn't look like Broadmead, doesn't look like Oak Crest, Ginger Cove, my grandma was at Edenwald, you know, those are all, well, good, you know, in good standing, and I'm sure Asbury is as well. So just looking for your thoughts on that. Do you want to
speak to the grievance procedure process maybe and how you work when there's a...
Sure. So as we mentioned, Department of Aging has the required grievance reporting, as well as if a resident files a grievance, so let's say it's financial, we would respond to them in writing and provide a meeting with that resident with a resolution. We also would offer third-party mediation in addition to that. But as far as to being outlined in the contract, one, it's covered in grievance, but the contract encompasses the regulatory requirements, so I would also refer to that in addition to that, meaning like all of the financials are available. Just the bill last year required that the financial disclosure statements actually have to be posted on the website. So the contractual obligation is between the residents and the organization and what they are due.
Okay. Thank you.
You're welcome. Okay. Delegate Tavares.
Thank you. So I really appreciated what you said in terms of the different types of products that you can offer and that people can choose. Mm-hmm. But I just want to be clear that there is a product where people aren't able to switch out. Is that correct?
No, that is not correct. So there is different products because there's like a life care, but then each contract spells out, and this was also part of legislation as well from years ago, what the entrance fee, the monthly fees, the refund policy is. And then there's also timelines, especially if you move into your CCRC and you're not happy, there's a special provision that for you to be able to move out and get a return on your refund that you put in.
Like a probationary period.
Excuse me?
Like a probationary period?
Something similar to that, yes. But there's never a time that you are not, when you sign to come into a CCRC, there's no product that says you cannot get a refund at a time. It is dictated within your contract terms.
Okay, thank you.
All right, seeing no further questions, that completes this panel and the bill before us, the hearing on the bill before us. And Delegate Tavares, your panel's not here. Are you ready to go ahead without your panel? Okay. So we are going to now move to House Bill 88, Health Insurance Bulk Purchasing Pools for Prescription Drugs. Delegate Tavares.
Oh, sorry about that. So I hope I don't disappoint, but it's just going to be me. Yeah, one of my panelists was pulled into an urgent meeting, and the other one has to go pick up her baby in school. So just let me know when I can start. Thank you, Madam Chair, Collison, and committee members. As always, it's an honor to be before you all today. I'm here to ask for your favorable report on HB 88, Health Insurance Bulk Purchasing Pools for Prescription Drugs. This bill proposes a critical framework that would authorize the legal private drug selling industry, such as a private hospital and independent pharmacies, to join bulk purchasing pools to negotiate lower prescription drug prices. This initiative aims to harness collective buying power, secure better prices from manufacturers, and achieve significant cost savings for industry partners, prescription drug insurers, and patients. These cost savings will directly impact the health and financial well-being of families across our state. This negotiating capability already exists for our state's Medicaid patients and our state personnel and individuals on the Maryland Health Exchange. Through this legislation, we seek to provide a practical solution with far-reaching benefits that is equitable across the entire market. So HB extends this proven model to the private market, ensuring a more equitable and consistent approach to drug pricing statewide. Participation under this bill is voluntary and applies to insurers, nonprofit, like I said, health service plans, HMOs, and PBMs, managed entities operating in Maryland. It builds on successful national models, including the National Medicaid Pooling Initiative and Top Dollar Program, which Maryland already uses. So I'll stop there. I think if you guys have any other questions, I think that we have a I just want to ensure that we're trying to improve the affordability and access of regular drugs to in the private marketplace. And in closing, I ask this esteemed committee for your favorable report on HB 88.
Truly appreciate your innovative thinking here. Have you had a conversation with the carriers about whether or not this is prohibited in any way?
With who?
The carriers, the health insurance. Is this prohibited?
No.
Or they could do it now?
I don't think it's prohibited. I've spoken with anyone. They don't. Let's just say that they're supportive, but they don't want to get on the record.
Yeah, I see that they didn't submit any testimony, so.
Everybody's been spoken to.
Okay. All right, thank you. Delegate Hill.
Yeah, so looks simple, straightforward, and I guess it's sort of piggybacking on the chair here. Why does it require permission or a mandate that we allow them to do this? And why hasn't it been done before? You may not know, I just don't understand.
Well, I'll just say, from my understanding and in the conversations that I've had, or how this came to be, based on conversations we were having kind of like at a national level from where in the conference that I attended on this matter, right? Some of it is just personality driven, right? Why do we have it and don't employ it, right? Who's gonna be the big dog to negotiate? And so I think it's more personal than it is about, I mean, I can't speak for, I can't speak for why the private industry hasn't done it, but I can just speak for
state,
for the ones where we are in, because it goes across 50 states, right? We can achieve the ones where there's control, right? The federal government has control, so they're controlling the conversation with Medicaid. We may control some of the conversation, maybe with the state plans.
All right, thank you.
But in the other ones, I think they haven't.
Thank you, Madam Chair. A similar question, have you talked with any of the PSAOs or any of the national community pharmacy associations to see if this is even possible?
The community.
The PSAOs do all the negotiating for the pharmacies on their contract, the reimbursement rates, all of that.
So I haven't spoken with maybe those people specifically, but I did speak with as many people that I came across, like the hospitals, Kaiser Permanente that was supposed to be here, you know, and everybody was on board. Everybody found it to be a value added for them and a tool in the toolbox for them to get cheaper prescription drug rates. And obviously, AARP was supportive, and a lot of the folks that are in their coalition.
All right, thank you. Thank you, Madam Chair.
Seeing no further questions, that completes the hearing on House Bill 88. Thank you very much, Delegate, and the work before us today. I would ask the committee to stay in your seats for a few minutes while we go down offline.